being late. I think that I'm happy having been late because the surgeons were so good that possibly it would have been a disaster to have me there. Anyway, thanks very much. These are my financial disclosures. Well, I will not repeat this quick story of hemothelial keratopathy in these last few years, and still the debate, of course, between which is best. Advantages and the disadvantages between the neck and ultra-thin the sac. If you look to the published the neck complications, it's a little bit a nightmare because possibly we do not have enough data, enough long-term or mid-term data, because it's slightly confusing. For some groups, rejection is extremely low. For some others, reviewing their experience doing the neck and the sac, rejection is higher. So I think that we still need to wait a little bit more to really know what's for most worldwide surgeons this mid-term complications rate compared with other procedures looks like. I will focus only in some of them has already been reviewed by much better surgeons than me and very experienced surgeons, but I will show you some of the tips that I've used in some particular complications. As my Dr. Fogla mentioned, still in Spain, there are not in every eye bank we have pre-stripped tissue, so quite commonly I need to prepare my tissue. So in these cases, I like to always look the staining pattern. If you see on the left side video, this ink in the posterior part of the graft makes me aware that there might be complications at the time of the touch decimate. I don't like to see them, but I always try to strip this tissue, but I know that there will be complications. In fact, it is quite common that I have radial tears with these difficult detached grafts. There is no problem with managing decimate tears, as you are aware. We can, in fact, there has been a proposal by Garrett and by some others that perhaps we do not need to use a complete 8mm graft, that we can work just with half a graft to obtain a clear cornea for a quite long term. And then in some countries, the use of just half a donor cornea might be enough. So you can easily handle these radial tears once you have the roll. I like to do my rexis under air, and I use a pump. I do not like to use viscoelastic, despite that the results for most surgeons using viscoelastic are extremely good. So possibly I might change in the future because it's possibly more comfortable. But generally speaking, I like to use air. I like this. I use this injector, and the only recommendation, the only tip, if you have radial tears, as you will see a couple of cases later on, is that once the way you'd like to inject the air is from the side where there are no tears. I think that because if not, you might have some faults. If you inject the air from the other side, the application of the membrane will be easier. Another quite or relatively common complication is visualization. Of course, in those cases you always need to have it, but in this case it's more proper staining. I like to use the one that the retinal surgeons use lastly, at least in my institution, which is brilliant blue, is the one that stains longer. And so for those cases with difficult visualization is impossible. Of course, a wide desepitalization will help you in most cases. And also, I do not like to use viscoelastic. As I mentioned, I only put viscoelastic once I have the roll inside. And sometimes, instead of using coaxial, if you use oblique lightning on the microscope, the visualization would be much better. And of course, as you have seen in the lower video, you can also use the intraocular probe to help you in the visualization. So indirect lightning on the microscope is possibly, from my point of view, one of the best, with low intensity, is one of the best ways to improve visualization in those difficult cases for visualization. Another thing that has been already mentioned, as you will see in these two videos, is that if you have any pressure on the outside, you might have complications. Look at that. When I was releasing the pump, because it was still a little bit open, despite that I asked my technician to have it closed, we have this flow. And in the other case, in the left case, was myself injecting a little bit of air. So as soon, you need to have a soft eye, and as soon as you have the roll inside, you should close your incision, except if you're using a very, you can use it with a suture, or you can use it with water, as Yanni nicely shown us before. Another complication, if you're using this kind of injectors as I am using, is that if you do not have a air bubble on the tip of your plunge, the decimal, as you have seen here, might be, as may happen also with lenses, might be in between. This is a disaster because you break the membrane. Of course, if you have another membrane, you can do it. In this case, I basically decided to go inside, despite I knew that I was going to find these several breaks on the membrane. I put an air bubble to basically see the extent of the damage, and then follow the positioning of the membrane, and obviously, as I mentioned before, inject from the nice side in order to try to escape from falls from the breaking sides. Well, fortunately, in the early post-op period, this eye went very nice, but of course, this is the eye after some months. But as you can see on the lower side, the endothelial cell count at 6 months is relatively low, and possibly it will be a problem on the long term. Again, difficult unfolding. The main risk factors are very young donors, improper roll, quick anterior chamber outer reformation, which is typical of aphakia and post-vitrectomy eyes, as it has been mentioned by Professor Fogler, or those cases with high vitreous pressure. Well, there are some different tips, but the best is trying to have not a very deep anterior chamber, but sometimes that's difficult. So in those cases where you cannot escape from having a deep and very quickly reformed anterior chamber, I come back to my old technique using some air in front of the membrane, and then once I have the membrane adhered over the iris, then I take the air out and inject the air underneath. So let me just show you the 4 videos at the same time. This is on the left. On the right downside is an ICE syndrome with synechiae. On the left, also synechiae, aphakic. On the top, they are not running. On the top is also 360 degrees synechiae with a tube in the anterior chamber. The lower left has 2 tubes in the anterior chamber, and the last one is a aphakic eye. This is one of the most, the existence of synechiae, from my point of view, is one of the most important situations where you need to measure your implant. So the ICE syndrome, I had a pre-op OCT, so I knew that except if I was planning to break the synechiae, I cannot use a more than a 7 millimeters implant. On the left downside, I was wrong. I did not take this consideration, and I used an 8.5, and it was extremely difficult in this aphakic eye with cubes and with anterior synechiae to open. Again, in the upper right, I was able to know that 8 millimeters was going to be okay, so it worked. And on the upper side, the aphakic eye, the problem was, as I mentioned, because it was a vitreous eye side, is the deep anterior chamber reformation. So that's why I used this air bubble in front. But in these aphakic eyes, if you use too much air in front, you might have what you have seen, that the membrane goes through the pupil. So despite that this air in front works to help you in this quick auto-reformation, it might be dangerous, especially in these aphakic eyes. So this is another situation where I've been involved in a couple of times. Pseudoaphakic eyes with posterior capsulotomy might look like there is no vitreous problem preoperatively, but during the surgery and because of these compression maneuvers, you might have vitreous strands coming up. So you might need to do some vitrectomy, as I did, but despite of that, postoperatively, this vitreous can go up and attach the membrane, as you can see on the upper side. So what I needed to do, because this vitreous strand detached my membrane on the upper side, is come back and do an anterior vitrectomy and be sure that this vitreous strand has disappeared in order to leave the eye without that risk of constant detachment from the superior side. And centration might be a problem. My recommendations is that, of course, you can use the tap tip, but sometimes, especially in cases where there is a significant iris atrophy, the adherence, because of surface tension of your lenticle over the iris, will not allow with tap tip to move the membrane. So you can use this forceps, especially designed to go through a 20 gauge that are very large, and so the pressure that exerts over the membrane does not break it, because if you use a standard intraocular forceps, you will break the membrane. So I think that we are finalizing. This is a primary failure. When you have a detachment, although Mark nicely shown us a very nice technique to do at the slit lamp, I personally very much prefer to go down, and instead of injecting air at the same time I am taking out liquid. So these are different ways, and who knows which is the best way to do it, but I like to inject the air from the side that the membrane is attached and extract water from the side that the membrane is detached, and do it at the same time IA irrigation. And finally, I'd like just to, the rejection episodes are quite difficult to be diagnosed sometimes. So I think that OCT images, consecutive images and follow-up images with the OCT might be especially useful, together with, obviously, clinical evaluation. And I just would like to finish with this rare complication, because this is the only case I've had, but this is a lady who had diplopia because of the inferior iridectomy. And it was, I tried to convince them not to do nothing, of course, because it was, but finally I needed to closure the inferior iridectomy to escape from the diplopia, which is not very comfortable. It's not very difficult, of course, but anyway, it was quite strange to me, because after a significant number of the mechs with a similar inferior iridectomy, this has been the only individual who has had this problem. So in summary, the mech, as you have seen throughout this nice meeting, superiority over other techniques of endothelial transplantation, despite still today there are some discussion about which is best. The learning curve is possibly longer, not too long, but I think that it is one of those examples where high meticulosity in every single step is mandatory to perform them. Thanks very much for your attention.